Good evening, everyone. Here Imran Abbas from Dubai. Again, we are live. I am from Dubai and Professor Asim Shabir from Singapore. It is great opportunity for all of us, especially for myself, to know more about sleeve gastrectomy. As you all know, we have started this interview series of safe sleeve gastrectomy since July 2021. We have started this series with Professor Patrick Noel. He's a well-known bariatric surgeon. And now we are going to go ahead, and also we had many well-known bariatric surgeons. Today, another legend of bariatric surgery, a well-known bariatric surgeon. Personally, I have a lot of inspiration from Professor Asim Shabir. It is great honor, sir, and really it is feeling great honor and privilege to interview such a prestigious figure. Sir, over to you.
Thank you very much. A very good evening and assalamu alaikum to my audience. Thank you, Imran Abbas, for the great honor to come onto this platform and be able to represent the bariatric community. And thank you for inviting, especially on the platform for sleeve gastrectomy, something which is close and dear to my heart. I'm Asim Shabir from the National University Hospital in Singapore. Originally trained in Pakistan, but then moved to Singapore, where I completed my advanced training. And I've been here ever since then, and I practice in a university setting with the National University of Singapore.
Sir, so much thanks for accepting our invitation. And I must highlight here, so all of these questions that are I always personally ask to my guests. So these questions also Professor Asim Shabir, so he helped me when I was going to start this series of safe sleeve gastrectomy. We talked in detail, and Professor has a main role for arranging these questions. So definitely we will continue this series till December 2021. And in December 2021, we will have a sum-up session at that stage also. Then again, we will have these legends, and we will discuss in detail what is our objective. So our objective is to convey message, safe sleeve gastrectomy. Sleeve gastrectomy is not bad surgery. Till this time, sleeve is the most common bariatric surgery at this globe, but unfortunately, we face a lot of complication. So the theme of these interviews, so you know better, interview in light mood, such a legend, such a expert has time, and I will ask question, you can ask question, then we can know better about tips and tricks, some technical points. How can we do this safe sleeve gastrectomy? Sir, we are interested to know about your journey of bariatric surgery.
I'm an accidental bariatric surgeon. When I finished my training in upper GI surgery, in the setting that I have been trained in upper GI, we do oncology work as well. We do benign upper GI work, and we added a portfolio of bariatric surgery. And I was tasked to develop bariatric surgery. We are some of the early movers of bariatric surgery in Singapore. It it did used to happen in Singapore, but in very few numbers, with very few trained people actually, or actually no trained people, particularly doing bariatric surgery. And then we came together under the leadership of Anton Ching, Shankar Pasupathy, and we came together to form the Obesity Metabolic Surgery Society of Singapore way back in 2010. And I started my journey in 2009. That's when I started training. 2008, I was introduced to Professor Huang, Professor Wee Jie Lee, and the great honors in IFSO and ASMBS. And that caught my interest. Moved on in 2009 to conduct workshops. 2010, did a fellowship with Huang. And since then, it's just been on the road. So been a student of bariatric surgery ever since.
Sir, excellent. So, sir, now more than 1 decade, so you are doing bariatric surgery. And why you have started a sleeve gastrectomy? Is a sleeve was your first surgery?
So when I was inducted into bariatric surgery and when I opened my eyes, that was the time when the band was at its peak. There were a lot of people putting in gastric bands, but as I trained, the hype of the band went away because we were now getting more and more complications and reports of failures. And at the same time, sleeve gastrectomy was becoming popular. So it was the talk of the town when I started training, and thus I grew up doing sleeve gastrectomies as some part of my training.
Sir, excellent. Sir, but because we are also interested to know evolution of especially that steps that during this journey of your bariatric surgery, especially this last decade, you are doing now a sleeve gastrectomy. Has your technique evolved over time? So if possible, can you highlight those steps or points to decrease the chance of complication after a sleeve gastrectomy?
So Imran, I think not only my journey with sleeve gastrectomy, but my entire journey with bariatric surgery hasn't come to a standstill yet. So I started with doing bands, then I did majority sleeves, then I introduced bypass, then I have introduced one anastomosis bypass, and now SADIs into my skill set. So it's been a journey that is continuing to evolve. Has sleeve evolved? Yes, I think my technique for sleeve has certainly evolved. Again, when I was trained, there was a hype for single incision sleeve gastrectomy. There was a lot of fashion for single incision surgery. We were trying to do single incision surgery. That's how I honed my skills. I used to do what is truly called a vertical sleeve gastrectomy, then went on to do taking part of the entrum along the way. Started off with a 38 French bougie, migrated to a 36 French bougie, was a hugger. Now don't believe so much in hugging. Before I used to stay very close to GE junction. Now I'm away from GE junction. Along the way, I think the most important thing that I have done in my journey and I've learned from my journey is that technical skills are one part of what we do for our patient. Perioperative care makes the most of what we do for our patient. And this is something, this is an art that we all ought to learn so that we can basically manage our patients much better. Decreasing complications, preventing them is to know your anatomy very well, to know your tools very well, your energy devices, your staplers. And last but not the least, you got to have a big heart because every surgeon one day will run into trouble. You should be prepared for the worst scenario to bail yourself out without anybody having a look over your shoulder. And that's the true test of the pudding.
Sir, excellent. Sir, you have highlighted pre-op. So can you mention which points are most important for a patient selection for a sleeve gastrectomy?
So I think I think if you read literature in journal, anybody who fits the bill for a bariatric surgery would essentially fit the bill for doing a sleeve gastrectomy. I would say I will start with the lamest of the criteria, which is BMI. I was a proponent of sleeves for super obese patients, but the outcomes are not as I thought they would be after doing a few thousands of these. And I feel that maybe not the ideal choice. I would shy away from them. I have treated patients with pre-diabetes. I think they're okay. I think the late diabetes do well. The very, very late burnt out ones do well with the sleeve gastrectomy. The middle cohort is not something, those who are newly diagnosed 5 years, I think you can still rescue them with better procedures like bypass, who deal with metabolic diseases. In general, patients with special needs, elderly patients, very young patients, I would be more prone to offer them sleeves. People on steroids, I may be more prone to offer them. People with diseases like Crohn's, endemic with gastric cancer, those who may not want to give up smoking at all and run the risk of anastomotic ulcers. And those who have preconceived ideas, which I cannot change about sleeve gastrectomy, because I have patients who walk into the clinic and say, well, my sister had a sleeve, my brother had a sleeve, they're doing perfectly well, and I want to have a sleeve. And I think it's reasonable to offer them. Apart from active psychological diseases, I don't see any big contraindication to selecting sleeve. I think it provides, if you do it reasonably well, it provides a good quality of life, good quality of control of morbidities, and a safer profile for the surgeon. The myth that sleeve is actually a safe procedure, is a simpler procedure, I think is a misunderstanding. Sleeve might be perceived to be safe, but the most difficult thing in nature are the most simplest things of nature. Right, so that's my perception of sleeve, and every sleeve teaches me a lesson, and I learn from it despite doing a lot of it. So that's where I am.
Sir, excellent. So why I have asked this question, because we have a lot of viewers, those are youngsters, so this is a great message for them. So sleeve is a simple but difficult case, difficult surgery, and patient selection, MDT, is very important. You cannot say just there are some staplers and there is no issue. So this was a great message. Sir, my question, I will continue about technical points. So you have highlighted vertical sleeve gastrectomy, and then now you are taking interim. So personally, so what was the difference?
I think the impact on weight loss is probably not so much. Right. If you look at the main difference in weight loss between those who leave the interim versus those who do 5-6 centimeters of interim and then cut the rest of the interim, there's not much difference. The actual difference is only in those people who actually measure only 2 or 3 centimeters of interim from pylorus. And that means essentially the whole sleeve is tubularized. Now, we need to understand the physiology. Apart from resulting in early satiety, there are other non-surgical related mechanisms that will thus kick in, which will help the sleeve act and do what it needs to do, which is weight loss for the patient. So with the vertical one, we just go straight along the bougie all the way. I felt that the ability for the patient to eat and keep the food, they had satiety for longer periods of time. But the volume consumed by patients was also more. So I felt the need to restrict that volume a little bit more. If we continue to tighten the bougie size, it makes a difference. But what you then start getting is an hourglass appearance of the sleeve, because you have the sleeve in the center, which is 32 French. Then you have a dilated antrum. And then what happens in the proximal part is the esophagus, like the band, if you keep it tight for too long, will start having compensatory dilatation. So I believe that weight regain in future may come from these very dilated antrums with a little dilatation of the sleeve. So I do take a portion, a reasonable portion of the antrum away, but I still stay about 4 to 5 centimeters away from the pylorus.
Sir, excellent. So it means, so now you are happy when you are near to pylorus and you are taking antrum for long time results of your sleeve gastrectomy.
Yes, in the longer time, I think it pays back well.
Okay. So also you had mentioned, so bougie size 38 to 36. So what was the difference? What is your personal experience? So now, because this interview is sharing your personal experience. Yes, you were doing 38, hugging the bougie, now 36. What was the difference?
Okay, the factual difference between a 36 and a 38 is actually hardly any. All right. In terms of weight loss, no, not very different. The companies that used to make 38 bougies fell apart. Now what we get is a standard is a 36 French bougie, and that's why we've gone to it. So I guess for the youngsters to learn, and what I have learned, when I started my practice, I would put a bougie. If this is a transectional section, I would really hug the bougie. I would hug the bougie so much so that I will pull the stomach apart and actually take away its elasticity and then staple, which meant that in a resting state, the actual 38 French bougie site may actually be 32, may even be lesser than 32. When you take out the bougie and the stomach relaxes, the lumen from this is probably even narrower, because you pull, it's like pulling an elastic socks till there is no more elasticity and then you divide. I don't think that works in the very benefit of the patient. When I look at my early series and with where I was a hugger and where I used to really pull the stomach in, I find that more of my patients had reflux. And they suffered reflux, which was more severe as compared to those that I have done later in my career, where although I have used a 36 French bougie, but I have loosely hugged the bougie, which means I have not taken away its elasticity of the stomach. I've just brought the stapler next to the bougie and just cut it instead of pulling any further out. My dissection of the angle of His is now limited to just looking at the left crust. I just don't mobilize the entire system of the left crust, because nature has made the stomach adherent to the left crust for a reason. If you do that, then the chances of sleeve migration upwards when weight loss happens is a greater chance, and thus increasing reflux. So I kind of stay about 0.5 centimeter to 1 centimeter away from the GE junction. So my stapler never goes between the stomach and the left crust medially. It's always on the lateral side. And thus I try to have a straight line all the way from angle of His all the way down, curve along the incisura into the antrum, and generally taper off at the distal antrum.
Sir, excellent. Sir, sometimes, I think definitely, about the article of Hempen about biphasic reflux after a sleeve gastrectomy. So that was after 1 year and also after 6 years. The main cause after, I think, 6 year or 5 year or later, GERD after a sleeve gastrectomy was that fundus that progressively, so the size of fundus become so this increased and that caused that GERD after a sleeve gastrectomy. Definite, about this. So this again, this is the message for our youngsters. When you are doing a sleeve gastrectomy, so you must be near to EG junction, just 1 centimeter, and not so far from EG junction. Sir, I am correct?
Yes. So I think, Imran, the most important concept is that we need to look at the stomach not as a flat organ. The anterior wall of the stomach is flat, but the posterior wall of the stomach is more lax. So when the stapler goes in, we think that we are stapling straight, but what we're doing on this side is we are leaving the stomach on this side behind, which then creates a dilated pouch and neofundus, and then it grows. So whenever you take the fundus, whenever you take
याद नहीं रहा उसको, याद नहीं रहा कि उसमें कह रही थी कि वो
Okay, so when you pull the fundus, you pull it towards the left side so that the sagging portion of the posterior fundus is taken care of. So, but you're absolutely right. Stay about 1 centimeter, leave that angle of his that is there to fix on the left crust of the diaphragm.
Sir, so much thanks. Sir, we will continue our interview. So what is your opinion about pre-op endoscopy?
100%. I endoscope all my patients, whether they are going, no matter what bariatric procedure they go for. I personally believe that it should be done. We had published some time back, now quite a long time back, in obesity surgery, and showed that at least in the Asian context, it made a difference. We were able to diagnose cancers. We were able to diagnose GIST. We were able to avert injuries because of ulcers and other pathologies, which could be easily corrected pre-operatively before venturing into surgery and having a disaster. So I believe that it is fundamental, key, and it should be standard of care.
Sir, we are scientists, and as I know, so you are also practically scientists. So if you compare how many patients, if you compare, because now 100% you are doing pre-op upper gastroscopy, how many cases change your plan after endoscopy? If you percentage, ask percentage, and that endoscopy was effective.
So if you just use one benchmark, Imran, which is change in plan for surgery.
Yeah.
Okay. So you see, to me, it means two things. Firstly, it means delaying surgery and changing a procedure to another procedure. All right. So delaying surgery, it makes a lot of impact, because if you get Helicobacter pylori in this part of the world, we believe in treating it. If you get GIST, you deal with it. If you have ulcers, you treat it. If you have suspicious cancer lesions, you diagnose them. All right. If there is gastritis, you make an effort to treat it. If there is, you diagnose hiatal hernia, you have a plan of changing procedure. I think totally change in procedure is probably less than 5% in my practice with endoscopy. That means I would change 5% of my patients who are going for a sleeve gastrectomy after taking a detailed history to either bypasses or some additional procedure to be added to it.
Excellent, sir. Sir, because as you know better than me, so most of the countries, so they are doing upper endoscopy only in symptomatic patients. But I know in that part of the world, Singapore, Japan, and there is, due to GI cancer, especially gastric cancer, there is more concern, and routinely they follow upper endoscopy. What is my question here? So in your practice, how many cases you have diagnosed malignancy, there was no symptom, just patient consult for bariatric surgery, routinely you did endoscopy, and there were some lesion, biopsy confirmed, yes, this is malignancy.
So, Imran, I think I can't remember the exact numbers we published in terms of patient numbers. We picked up 1 adenocarcinoma. We picked up 3 gastrointestinal tumors that required treatment beyond being part of a sleeve gastrectomy. All right. And we severe acid peptic disease with deep ulcerations. We had about 4 or 5 of them.
Okay.
So in terms of cancer, I think we only picked up 1 adenocarcinoma and I think three or 4 GIST.
Sir, what about H. pylori? So you have mentioned, yes, H. pylori eradication is compulsory. So again, my same question. So what is the percentage of positive cases of H. pylori in your endoscopy?
Probably about 10%.
10% are positive. Are you follow these patients after a sleeve gastrectomy for H. pylori after 3 months, 6 months, 1 year, or no? Then there is no need to follow for H. pylori.
So what we do is before operation, we delay their operations. We give them triple therapy, treat their H. pylori, and we do a urea breath test to document eradication. And only then we go ahead and sleeve them.
Okay, sir. Sir, what is your protocol for post-op surveillance, endoscopic surveillance? So what is your protocol?
I don't have a standard protocol, but I believe it should be the standard of care. If not year 1, at least year 3, it should start. And then it should probably, I would, if I can go back in time and convince my patients, I would say I would do it at year 3 after surgery to see whether they have any reflux esophagitis. Are they developing any Barrett's? Is there any hiatus hernia that is coming up? And to pick up the asymptomatic ones earlier. And then depending on that, I will base my further surveillance endoscopies.
Sir, again, you will go for selected cases or no, for all your cases?
So Imran, okay, let me put it this way. From the endoscopy experience that I have had, when I now look back at my series of sleeve gastrectomy as patients who actually are now presenting with GERD.
Yeah,
okay?
This was my question.
And we're talking about 3 years, 5 years down the road. These are those patients who actually had LA grade A or early B esophagitis, right? These are the ones, you see on the endoscopy and say, I don't know, this one, it's okay. You don't have to worry about this one, you just kind of ignore it. Now, 5 years down the road, they're coming back and haunting me. Whereas the C's, the D's, the late B's, I did not treat them with sleeve gastrectomy, or I treated them with sleeve gastrectomy with hiatal hernia repair and did a proper anti-GERD surgery for them as well. And they are well. So my take is that if you have left these patients, they're symptomatic, please go back and scope them. So do I do selective endoscopies? At the moment, yes, I practice the same. I do not do post-operative endoscopies for all my patients. The systems will not cope with it. It's a heavy burden. Would I love to do it? Yes, I would love to do it if patients agree. But generally, after 2-3 years, the patients become more smarter and they actually just decline having endoscopies any further till they are symptomatic.
Sir, great message. So really now it is the need to go ahead for follow-up of these patients, then definitely we will face less complication, especially late complication, and hope very soon, because you are the person who are making guidelines for all over the world, and definitely you will be effective, sir, and you can do and you can follow this, and then this will be a guideline from IFSO or from other bariatric societies or any bodies. Sir, regarding absolute and relative contraindication, already you have mentioned some points in pre-op and patient selection. I want to hear from your side, what is your this absolute contraindication of sleeve gastrectomy?
Imran, I don't think there is any absolute contraindication other than psychological illness that is not treated. Yeah. And if that is the case, I think that's the only absolute contraindication for any bariatric procedure, including sleeve. Relative contraindications, I try not to, I would say that those patients who have reflux, whether they're symptomatic or endoscopically found, not to push them towards sleeve gastrectomy. I think then beyond that, to me, there is no real contraindication for sleeve gastrectomy.
Sir, excellent. You are a brave man. And I know, because especially this esophagitis, I know Barrett is very rare. So definite Barrett is not a common findings. So this is, we all know this is, Barrett is rare. But again, always we discuss about Barrett esophagitis. So you will go for sleeve gastrectomy in such a case?
Okay, so Barrett's in its own, as I said, anything to do with reflux, I would try not to do a sleeve gastrectomy. Anything to do with reflux, whether that's A, B, C, D, esophagitis on endoscopy, patients having symptoms with mild esophagitis or Barrett's for that, I would try not to do a sleeve gastrectomy for that patient. Now, Barrett's in its own, we must look at it in a different perspective. We have a study that has just opened up looking at Barrett's esophagus, its relationship to obesity, and what bariatric procedures are contributing to, and whether Barrett's in bariatrics is any different. We just opened the study with one of our basic science colleagues, and we're looking into it. But well, we must also understand that the Caucasian Barrett is different from the Asian Barretts. Our Barretts are generally short segment. They don't have a high propensity of going through into the adenoma carcinoma cycle as compared to Caucasian Barretts. Having even said this, I would not subject my patient with a Barrett's to a sleeve gastrectomy.
Sir, excellent. So really first time I hear about this difference between so Asian and Caucasian. So a great message, sir. Sir, just because we had such a case that now I will highlight a male patient, 45 years old. He has a previous laparotomy due to trauma, and also resection of colon and also some part of small intestine, ileum, about 5-6 years ago. Now the patient is diabetic and also GERD, and in upper endoscopic finding was Barrett esophagus. So you will go for fundoplication or sleeve gastrectomy in this case? What will be your preference?
What's your BMI here?
BMI 32.
And you are basically treating the patient. So the primary intention of the patient is what? The patient has come for weight loss surgery or for reflux?
So for reflux, but he's also interested to decrease his weight as well as diabetes. So because now we know, and most of people, they know about metabolic surgery, and due to previous laparotomy and lot of adhesions, there was no chance to mobilize small bowel for Roux-en-Y gastric bypass. So, but will you do in this case? We have two options only. We can go for a sleeve or fundoplication.
Okay, you cannot do a bypass.
We cannot do.
Okay, then I would just do a fundoplication. I won't do a sleeve.
You will prefer in
Right, the patient is still very young. There are a lot of good medical therapies for diabetes. As surgeons, we also, like our medical colleagues, need to believe that we cannot rid the entire world of disease. We need to do what is safe and just for the patient. 32 BMI is not a very huge BMI. Certainly a bypass surgery or sleeve can make a difference, but doing a sleeve, on the other hand, when he has GERD and Barrett's already in place, is going to be detrimental. Sometime sooner or later, you will have to commit to a bypass, which in your case, you're not willing to. So I would just do a fundoplication and bail myself out.
Sir, excellent. Sir, as you have mentioned, so definitely you did many sleeve gastrectomy in case of symptomatic GERD. So you remember worseness of GERD after a sleeve gastrectomy in such a case who was suffering with GERD before surgery?
Yeah. So I have plenty of them. Okay. Because I started when people were doing sleeves left, right, center for everything. That's the time I did sleeve. A little bit of reflux, we always attributed it to obesity rather than understanding that post-sleeve it will worsen. We just went on, and I have a lot of these patients. So a lot of my patients who had symptomatic GERD earlier have now worsening of their GERD despite being on PPIs. They've been taking continuous PPIs for 5 years, 6 years. They continue to remain symptomatic. And I have converted a large number of these into gastric bypasses, and they are symptom-free. There are majority of these patients actually had esophagitis, but a couple of them, despite being on PPI, healed their esophagitis, but they developed hypersensitive esophagus. So a little bit of acid up there causes severe spasm and pain, and converting to bypass was a better option. I've thus far not regretted any conversions for reflux to bypass.
Sir, excellent. Sir, one of the main reason of GERD after a sleeve gastrectomy is high pressure of intraluminal high pressure. And when you will do gastric bypass, definitely we decrease. One of the mechanism is to decrease this pressure. So have you any experience to convert such a case to anastomosis gastric bypass?
Yes, I have done. I have done these, and I am doing them, and I am endoscoping them at 1 year down the road. So this is the cohort that I endoscope. I have converted to one anastomosis bypass, done a hiatal hernia repair with esophageal fixation. And thus far, they seem to be doing all very well. They're asymptomatic, and they have continued to maintain their weight loss. Quality of life almost similar to what they had, but without the GERD. So most of them are very happy with it. It will only be long-term that we would come to know whether there is any transformation of Barrett's, recurrence, and what percentage.
Sir, a political question, because we all know in low BMI or high BMI till patients, if patient is suffering with GERD, the gold standard, especially for GERD, for treatment of GERD, is Roux-en-Y gastric bypass, that we all know. So is in future, when anastomosis gastric bypass can take this name for...
Imran, you really need to then, if we want to go and tread on these 5 lines, then we really need to understand for each individual patient, what is the cause or what is the most pressing cause for reflux in that patient. There will be patients with Roux-en-Y gastric bypass where pouches are very big, and they will also have acid reflux.
Yeah, this was my, yeah. Understood.
Okay?
Yeah.
In one anastomosis bypass, the gastric bypass pouch is big. All right? And if you make the anastomosis 2 centimeters, because you see, the biggest problem that one of the problems that the bariatric community faces today is each and every surgeon's own innovative way of doing a procedure.
Yeah.
You know, they would do a long tube, which is wide, and then they will create a 1 centimeter anastomosis like a Roux-en-Y bypass. The food will not pass down. It will stay. It will result in dilatation, high acid production, and even a OAGB then becomes a refluxogenic operation.
Yeah.
Versus our nice 4 centimeter anastomosis, where the food will go to the small bowel easy without being obstructed, preventing any dilatation of the pouch in future. Right? Now, if hiatus hernia is the primary and main problem that resulted in GERD, then with a Roux-en-Y bypass, because there is so much more less acid, the patient will become asymptomatic, but reflux will still happen, right? Because you don't fix the hiatus hernia.
Yeah.
But for me, my principle is if there is hiatus hernia, whether the patient pushes me to do a sleeve or I do a bypass, whether that's one anastomosis bypass or a Roux-en-Y, I will always fix my hiatus. Yeah, if I believe that I will have to come back to refix this hiatus, then I will not. But for all practical purposes, I will fix my. So it is very important for us to figure out the why is this person having reflux? Is there an anatomical issue that we can solve before we decide and embark on the procedure? If it's a grade 4 paraesophageal hernia, I mean, you can fix the paraesophageal hernia. If you do it rightly, if you fix the esophagus, the likelihood of a recurrence of symptoms is low. But if you fix the hiatus hernia, make the sleeve so tight on a 32 French bougie, and you tighten it further to make it 28 French, then no matter what you do, the patient will have a reflux. So I think we also need to dampen our expectations of procedures. Just by making it tighter, and I mean, the best tight is you just staple the stomach off, right? There's nothing, it doesn't go in, everything comes out. So we need to leave something for the procedures to do as well. And so we should follow standard procedure guidelines and what is available. Issues like this need to be studied in larger trials to prove the correct and the wrong and dispel the myths before the general adoptance by the community at large.
Sir, excellent. Sir, you have mentioned also fixation of your esophagus with the lift crust. So what is the benefit? So this really prevent migration of stomach?
No, I don't think it prevents the migration of stomach. So if you look at the way that the hiatal region is reconstructed, at the angle of his and slightly below it, the stomach is adherent to the left crust of the diaphragm.
Yeah.
Which prevents the esophagus. The esophagus is like that spring band. All right. It's got those nice circular muscles and longitudinal muscles.
Yeah.
The work of the longitudinal muscle is to pull the esophagus into the thorax.
Yeah.
Right? So unless we fix it at one point, once you mobilize the hiatus, even after a sleeve or a bypass, and you make a small opening for the esophagus to pass, the longitudinal muscles will still pull the esophagus up. Unless you fix it, cause a purposeful adhesion, it will migrate. Now, that migration varies in different people. It may be 1 centimeter, 2 centimeters. In others, it may be migration of the entire sleeve. It depends upon how much mobilization you have done. So once I mobilize, I make an intentional effort to fix 3 corners of my esophagus, one to the left, one to the right, and one to the center tendon of the diaphragm. So I use absorbable sutures to fix my esophagus there.
Sir, excellent. Definite that you are doing. That is the exact anatomy before. That is the from nature. That adhesions are natural adhesions after dissection, after repairing of hiatus. So this is your message for our youngsters.
My message for the youngsters is, if you run into a patient who has reflux, try and convince the patient to go through a bypass procedure. Okay, it's a low pressure system. It is better equipped to combat reflux. But there are patients, and I have patients who would say, no, I just want a sleeve. You just fix the hiatus. If you do it, then the way to do it is do a proper dissection. Make sure you have 3-4 centimeters of esophagus, which is in the abdomen. Fix the esophagus to the central tendon and the left crus of the diaphragm, and close the hiatus snug to the esophagus, not tight, but snug, because the crura of the diaphragm provide to the competency of the lower esophageal sphincter.
Sir, sometimes when we do, because in obese patients and with the high BMI due to high intra-abdominal pressure, definitely we have some hiatal failure or hiatal hernia. We can name different names. Okay. When we scope in laparoscopy, when we see and we mention, yes, there is a hiatal hernia. Also, sometimes we can see a large size lipoma at that place of hiatus. So are you preferred to remove that lipoma? Why I am asking this question? Sometime when we will go after 1 year, 2 year for lab poly in such a case, then we can see, oh my God, this is, where was this when I did surgery? At that time, nothing. But now we have a large size, apparently hiatal hernia. Maybe this is just hiatal failure. So what is your opinion to remove that lipoma if we see a large size lipoma, but there is no hiatal hernia in your endoscopy?
So, Imran, that then means that you will be exploring all your hiatus. You see, you cannot see a lipoma that resides behind the esophagus without opening the hiatus. Once you have opened the hiatus, you have committed yourself to a hiatal repair. Correct? So that means if there are 20% of your patients who have hiatus, hiatal hernia, because you did not do an endoscopy on them, the 75% now have to suffer hiatal exploration. If out of the 75%, even 10% fail from your hiatal repair, there's no other person than me to blame for it, right? So as a norm, I do believe in doing endoscopies and diagnosing hiatal hernias on endoscopy and not doing routine hiatal explorations intraoperatively. And I would send the same message across that if you're looking for hiatus hernia, then look at it on endoscopy. Do not do routine exploration of the hiatus on laparoscopy. If you do find the lipoma, if you're dissecting the hiatus for whatever reason, you find the lipoma, I will 100% remove it.
Sir, why I am asking this question? Because our topic is safe sleeve gastrectomy. And one of the main issue after a sleeve gastrectomy is GERD. So there is no doubt. So nowadays, so this is the main issue. So just my question, yes, we take your message. There is no need to explore that area, that hiatus area. I have no idea. So I don't know. Is it will be effective if we explore routinely? No need.
You see, if you expect 10% of your patients to have hiatal hernia, that means you are doing an unnecessary intervention for the rest of the 90%.
Yeah, absolutely.
Okay. And if out of the unnecessary 90, 10 fail,
Yeah.
you have now increased your complication rate to much more higher folds, right? So no, I do not propose to do routine dissection of the hiatus for all patients.
Thank you, sir. Sir, regarding leak, so definite, if you personally, you have not faced any leak after sleeve gastrectomy, but maybe your colleagues referral because you are practicing in a tertiary hospital. So have you encountered post-sleeve leak? What technical tips do you have to prevent leak after a sleeve gastrectomy?
Okay, so Imran, I think I have 2 or 3 of my own. There's no shame in claiming. I'm no pious one. I didn't come doing all of them 100% well. I learned from my mistakes. Okay, so stapling too close. As I said, if you're close to the hiatus, angle of His, and you pull the stomach too much laterally, what happens is the staple will cut the lower esophageal sphincter. You will get necrosis, you will get leak. I have done it. Okay, in my early series when I was hugging and I was really hugging, I've cut the lower esophageal sphincter, and that corner, that superior corner, basically gave way, and the patient leaked on POD 3 or 4. The second leak I had, I overzealously touched the staple line with a diathermy to secure hemostasis. I normally do mucosal burns, very light touch, but I think that one I overzealously did it, and it basically caused heating of the staples. And later on, about day 7, day 8, there was a leak from that staple line. Have I had a burst staple line from narrowed incisura? No, I've had a stricture, but not a burst staple line. In terms to prevent it, I think stay away from the angle of His. Do not do more than the dissection that is required, because you do 2 things when you do more than required dissection. You increase the risk of GERD. 2, you damage blood supply around the area, which makes it more prone to leaks. Try and staple straight, so that you do not have a crooked spiral staple line that results in a raised intragastric pressure, sort of a pseudo obstruction, and results in a blowout. If there is a staple line where the end of the staple has actually eaten into the serosa and muscularis of your staple, then suture it full thickness at that place, because it's a weak staple line. The stomach's strength lies in its muscle and in its serosal lining, not the mucosa. So in that case, the staples are only hanging on the mucosa and it will surely leak. Avoid excessive use of diathermy, and be vigilant after surgery. If the patient is not progressing as you would like the patient to have progressed, there is something wrong.
Sir, excellent. Sir, I would like to know about your opinion about oversew or mentopexy.
So I think there are people who basically do a wide sleeve, and to be safe, they oversew their staple line. The best way to oversew staple line, if you belong to that group, is to do Lambert sutures and not bury the staple line.
Yeah.
Remind you, if you bury the staple line, invert the staple line, you may potentially be causing more ischemia. Right? And why are people oversewing the staple line? Do they not believe in the staplers? Or is it for bleeding? If it's for bleeding, I can understand. But generally, if the staples are well fired, the burst pressure of the staples with 3 rows of staples is so high that without a reason, it will not leak. Even if you cut the incisura, leave the staple line, I will tell you the patient will continue to vomit, but the staple line will not break.
Yeah.
Yeah, it breaks because we have committed another offense. like we have burned the staple line, we've made it ischemic for some reason, or we have left a mucosa, staples to the mucosa, or we have cut a major part of the serosa and muscularis of the esophagus, and the mucosa is exposed, that necroses and it leaks.
Sir, regarding Mentopexy, because also during this series, one of the well-known bariatric surgeon, he showed, if you remember, so he also showed me that his video and also live surgery and importance of Mentopexy. What is
Okay,
your
so Imran, let me put it this way. Why do people do Mentopexy?
I asked him.
Yeah,
I
and
asked
what
him.
did he,
He
what did he
also
say?
prevent this Mentopexy prevent migration and also leak and bleeding. And
Okay, so this is my take for omentopexy. When you have a cut staple line that is in front of you, if you put the omentum will adhere to it faster. Will it prevent bleeding within the first 24 hours, which is the most common cause of bleeding? The answer is no. Will it prevent a leak? The answer is no, but it will seal the leak. Yes, I can understand that. Will it prevent proximal migration of the sleeve? The answer is no, because the first place to lose fat, the first place to lose its fat content is the omentum. Okay, so what are we relying on? Are we relying on the bulk of the omentum, the weight of the omentum? This is the omentum that when we fast the patient, the first 5-10 kgs of weight loss all come from visceral fat, of which omentum is the biggest portion of it. Then if you talk about somebody going from 40 BMI to 25 BMI with 30 kgs weight loss, what amount of omentum is left behind to give a traction or prevent the sleeve from migration? I mean, in my mathematical sense, it does not make sense to me.
Sir, thank you, sir. Sir, one of the most common complication, not most, but if we compare with other bariatric surgeries, like with the Roux-en-Y, with the anastomosis, gastric bypass, is portal vein thrombosis in sleeve gastrectomy cases. Have you faced such a situation, and how can we prevent?
Imran, I've never experienced one. I hope I wouldn't experience one. I have read the experiences of others. Now, is this just because it so happens to happen in the place because there is propagation of a thrombus because of hemostasis in the region? Or is this really a whole coagulation related issue? The patient is pro-coagulant or has a sluggish blood supply due to hyperviscosity? I don't think we really know the answer. All right. So I think the standard measures of prevention for thrombosis, which is basically make sure patient remains well hydrated, ambulates early. If there is a complication, if patient gets pancreatitis or something like that, then I can understand portal vein thrombosis. For high-risk patients, maybe chemical prophylaxis using enoxaparin, fluoxetine, heparin, but I use that only for high-risk patients. I'm not saying about low-risk patients. Yeah, so I don't think the only technical advice which may or may not make a difference is every step you take has to be calculated. It should be, every movement in the abdomen needs to be purposeful, and just do a clean, safe, neat surgery without beating around the bush. That's it.
Excellent. Sir, this hydration is, so we always talk about hydration after a sleeve gastrectomy. That is much difficult, especially first 2-3 days, because routinely we discharge the patient next day. So now in Dubai, so one night stay. If patient will stay more, then more charges, you know better than me. Are you prefer to your patients for 1 liter, 2 liter serum after, so they must consult to a clinic and I don't know, 1 liter ringer every day for 2 or 3 days.
So, Imran, I do not have that kind of pressure that you have, okay? But let's take the cost of bending in that pressure. If you have one patient out of 100 or 1 out of 1,000 who has developed a portal vein thrombosis, is that not a significant enough trouble in one's life to keep a patient another day or two to hydrate him? In my opinion, it is certainly okay. If hydration is a problem, and it is a problem in your part of the world where there is extreme heat, okay? In Singapore, my practice is we keep the patient hydrated with IV fluids, only discharge if the patient can keep 1 liter of fluid daily down, minimum. And in your setting, that may even be 2 liters, because either they need to suffer the heat outside or the extreme cold inside, because the aircon is also dehydrating. Yeah. So I would suggest that we need to ensure, and if I tell my patients, if you cannot take 1 liter, give me a ring. I will arrange for you to come to clinic and I will give you a pint of fluids or 2 pints of fluid. You just lie down in the bed, you have. Do not go into renal failure. That's the worst thing you want your patient to land up. So you can put, if you have the pressure to discharge, then you should have a nurse to follow up with the patient the next day and say, well, are you taking enough? If you're not, would you want to visit the clinic back? Can we hydrate you in clinic while you catch up with your fluid needs, especially in hot climates and very extreme cold climates?
Sir, so much thanks. Sir, now you are practicing more than 1 decade. And also I know, and most of us, we know you are surgeon, also you are scientist. Definite, you have your data. Which percentage of your patients are suffering with weight regain after a sleeve gastrectomy?
So I think, Imran, the data is as good as what is collected. So I do have a very high attrition rate in practice after a while. So generally the best follow-ups are up to 3 years, and beyond 3 years, 5 years, it just dwindles and becomes meager. I would say about some degree of weight regain is virtually almost common in all sleeve patients beyond 3 years. Okay. When we talk about significant weight regain, I'm talking about 25%, 50% of lost weight regain. I would say about 10% of them would have significant weight regain. That is clinically meaningful. That has resulted in comorbidities coming back. That has resulted in the patient seeking advice because my weight has gone back to almost near where I was.
Yeah.
That's about anywhere between 10 to 15%. Yeah.
Sir, which percentage of your patient have you changed to Roux-en-Y gastric bypass due to intractable GERD after a sleeve gastrectomy?
I think we have, out of about 850 sleeves that we had done some years back, we have probably reversed about 30, 40.
Okay, a good number.
Yeah.
Yeah, a good number. So you have, sir, another also political question also as well. So what is your opinion about endoscopic gastroplasty?
I think it's a great procedure. I think it fills the gap that is much needed. Okay. I think we all have great procedures. We just need to match it to the right patient, with the patient accepting the outcomes of what he is going through. I think it's a great procedure. We are learning from the procedure. It may not have reached its mature state yet. It may be a bridging procedure. It will find its ultimate role in the armamentum against obesity and metabolic disease. It's just that we are basically reviewing it from a critique angle rather than being accepting of it, which is the future of bariatrics.
Yeah.
Yeah. No, I think we need to give it time to mature. It will find its place in the weight loss surgery arena. As surgeons, we should learn to do it. Because the future, it may not be my future, but it is definitely the younger generation's future, is endobariatric surgery.
Yeah. Yeah.
So there is no excuse. If you want to cut yourself out of practice, then welcome, don't learn endoscopy. But if you want to remain relevant in practice, you want your subspecialty to remain relevant to surgery, then do not give up endoscopy.
Agree, sir. Sir, excellent. Really, this interview, as I have predicted, one of the best interview, in my opinion. And personally, I have learned a lot. So much thanks, sir, for your time. And what is your message for our youngsters who are just now going to start sleeve gastrectomy?
I think it is important that we do whatever we do to the best of our abilities and knowledge, to learn from somebody who has gone through the learning curve of it, to be mentored, to do it as a part of a multidisciplinary team, to be fair to our patients and not being biased by what we can do. Because I can do sleeve gastrectomy, the whole world gets a sleeve gastrectomy is a wrong way of doing it. We need to personalize procedures. We need to personalize interventions to the needs of our patients. We need to continue to learn newer innovation and innovative techniques and come and be innovators ourselves. We should keep close to science and apply that knowledge that we acquire to our day-to-day practice, remembering that this job that we have been given is a very sacred job, and we are accountable. In whatever way you believe, we will be held accountable for our works.
Sir, so much thanks for your time. Now, I think 12 midnight across at your side of world, and so much thanks for your time. And also my viewers, so much thanks for following our series of sleeve gastrectomy. We will continue this series of sleeve gastrectomy, and next week, next Tuesday, we will have Alexander from Russia. He's also a well-known bariatric surgeon and also president of Obesity Society of Russia. And hopefully we will continue this series till December, and we will have such a great surgeon. If you have any question regarding today's interview, you can ask in your comments and Professor will answer. Sir, again, so much thanks, and definitely I need your guidance and support. Thanks a lot, sir.
Thank you very much, Imran. Thank you for having me on.
Thank you, sir.
Thank you.